randomized controls from 24 pediatric hospitals in the Overcoming COVID-19 network. Next slide, please. This evaluation, published in MMWR in early January, found that vaccine effectiveness of 2 doses of Pfizer-BioNTech vaccine against MIS-C was 91%, with a 95% confidence interval of 78% to 97%. 97 out of 102, or 95% of hospitalized children with MIS-C were unvaccinated. Of the 5 children hospitalized with MIS-C who were fully vaccinated, none required respiratory or cardiovascular life support, such as invasive mechanical ventilation, vasoactive infusions, or ECMO, compared with 39% of unvaccinated MIS-C patients who did. Next slide, please. In summary, this evaluation found that 2 doses of Pfizer-BioNTech COVID-19 vaccine reduced the likelihood of MIS-C by 91%. Of the people hospitalized with MIS-C during the study, 95% were unvaccinated, and none of the vaccinated people hospitalized with MIS-C required life support. This analysis provides support that vaccination of children and adolescents is highly protective against MIS-C and underscores the importance of vaccination of all eligible children. Next slide, please. Now it's time for a self-knowledge check. Which of the following are criteria to be considered when making decisions about starting COVID-19 vaccination in an unvaccinated child who has a history of MIS-C? The answer is all except one of these. A, clinical recovery has been achieved, including return to normal cardiac function. B, it has been 90 days or more since diagnosis of MIS-C. C, when they are in an area of high or substantial community transmission of SARS-CoV-2 or otherwise have an increased risk for SARS-CoV-2 exposure and transmission. Or D, duration of hospitalization. All right, next slide, please. So the correct answer is D, duration of hospitalization. Answers A, B, and C are all criteria that should be considered when making decisions about starting COVID-19 vaccination in an unvaccinated child who has a history of MIS-C. Regardless of duration of hospitalization, time should be allowed for full recovery from MIS-C, and a discussion should occur between the family and healthcare provider as to when the right time for vaccination would be. Next slide, please. So to summarize the overall contents of this COCA call, the CDC's response to monitoring MIS-C includes both passive and active complementary surveillance systems. These are the National Health Department reported surveillance, Overcoming COVID-19 network, and integrated surveillance for MIS-C after vaccination. The CDC has other focused epidemiologic investigations that are ongoing, including evaluations of incidence, risk factors, and outcomes of MIS-C. MIS-C resources are available to support healthcare professionals, and these include handouts on MIS-C symptoms and what caregivers need to know, key points for healthcare professionals to use when talking with families and caregivers about MIS-C, and clinical considerations regarding COVID-19 vaccination. Next slide, please. Lastly, here is a list of resources, and these will also be provided on the COCA website. Thank you. Now we have time for questions.
Presenters, thank you so much for providing our audience with such timely information. We will now go into our Q&A session. Please remember to ask a question using Zoom. Click the Q&A button at the bottom of your screen, then type your question. Our first question asks, how should clinicians report cases of MIS-C to the CDC's national surveillance systems? And when it comes to case definitions, do you have any plans for these case definitions? Do you expect them to change?
Yeah, thanks. This is Dr. Campbell. I'll take that one. I think, you know, we've really gotten all of our states and many of the territories on board now with reporting. And so clinicians would go through their local state or territorial health department, and then those in turn report cases to us. I think each state and each jurisdiction sort of varies in the approach to that. Each hospital actually, I think, varies in the approach to that. But you would go through your health department. And I saw there were a couple of other questions about some of the future contents of the case definition. So I'm glad that a few people have wondered about that. We are actually actively in the process of revising the case definition, and in the process of that, working to make a more efficient case report form. So in working on this, our discussions have been informed by the data that we've collected on cases reported to the national surveillance system, as well as that robust data set of overcoming COVID-19, and then another data set at CDC that was from a study designed to look at features of MIS-C compared with COVID-19, Kawasaki disease, and toxic shock syndrome, because these can sometimes be difficult to distinguish from MIS-C. So we interrogated all of these data sets so that we could refine the case definition a bit and remove some of the features, particularly even some of the organ systems that don't seem to contribute to the inclusion as a case. And then we are also trying to define the criteria, not trying to, we're planning to define the criteria for inflammation and the SARS-CoV-2 laboratory testing more clearly and more precisely than the broader definition. We are actually already working with CSTE, the Council of State and Territorial Epidemiologists, and the plan is that we will be working with them over the next several months, and there would be voting at the June CSTE annual conference on the new case definition. So it won't come tomorrow, it won't come in time for the cases that are likely to follow the Omicron COVID wave, but we are working on that. Thank you.
Thank you very much. This is a question we're seeing in a few different forms, and essentially it boils down to when should patients be referred to a higher level of care so they can be evaluated for MIS-C?
Thank you for that. This is Shayna. I'll take that question. But first, I want to acknowledge those who commented partnering with the American Academy of Family Physicians, and they're a very strong partner of ours, and you're absolutely right. They're one of our great collaborators in this effort. But to answer that question, parents and healthcare professionals should monitor children with a known or suspected history of SARS-CoV-2 infection or exposure for symptoms of MIS-C. MIS-C typically presents about 2 to 6 weeks after infection with SARS-CoV-2, and symptoms include fever and multi-organ dysfunction. Common symptoms include abdominal pain, vomiting, diarrhea, rash, non-purulent conjunctivitis, and dizziness. Many of these symptoms can overlap with acute COVID-19 or other viral illnesses, but patients with MIS-C generally present quite sick and require hospitalization, at a minimum for supportive care. Depending on the level of suspicion for multi-organ dysfunction associated with MIS-C, there are several lab tests that can be useful for further evaluation, including, but not necessarily limited to, CRP, ESR, CBC, CMP, BMP, and troponin. Certainly, any patient with any of the warning signs and symptoms, such as trouble breathing, pain or pressure in the chest that doesn't go away, confusion or unusual behavior, severe abdominal pain, irritability or inability to stay awake, and then discoloration of the skin, pale gray or blue. And then these patients should be referred immediately to the emergency room. Thank you.
Thank you very much. Our next question is regarding the safety data about children who got MIS-C after receiving the COVID-19 vaccine. Now that the younger children ages 5 to 11 are able to be vaccinated, are you also receiving reports of children who develop MIS-C shortly after they get this vaccine?
Yeah, this is Anna. I'll take this question. So we have been monitoring potential cases of MIS-C after vaccination in children 5 to 11 years old. And as of February 4th, we've identified 10 children who received COVID-19 vaccine and then developed an illness that met CDC MIS-C case definition. And we are investigating an additional 20 potential cases. But of the 10 children that we identified that have an illness meeting the MIS-C case definition, 7 also had lab evidence of past or recent infection.
Thank you very much. Our next question also seems to focus on vaccination a little bit. The question asks, do you know if it's possible to develop MIS-C after having been vaccinated for COVID-19? So from like, say, a breakthrough case of COVID?
Yeah, Anna, I'll comment on that from the surveillance perspective. I don't think I mentioned, we added vaccination questions to our case report form last May, and it wasn't, those fields weren't widely completed initially, but they have been more now. And so we are keeping an eye on how many cases reported to national surveillance are in children who've been vaccinated, and sort of the timing around that. And I know there have been at least 20 or so far, last I looked, that these kids had been vaccinated like 2 to 6 months before their MIS-C onset. So, you know, would really seem like a long enough window that they got a subsequent SARS-CoV-2 infection, basically a breakthrough infection, and they did present with MIS-C. I've seen a few questions. I'm trying to kind of have my answer address some of the others. We don't currently we don't have a field right now that's collecting information on booster doses, but we are planning to add that. And so I can't really comment on fully vaxxed and then boosted children having been reported who developed MIS-C. There was another question I thought, we also haven't really looked, well, we have looked, but haven't really seen any obvious differences in the clinical characteristics of the kids who were reported after having been fully vaccinated and getting MIS-C after what seems like a breakthrough infection. So I think that addresses the comments I saw about breakthrough. It does seem that it can happen. I don't think we're able to really comment on rates or how often, but we have seen some kids. I think the other thing I want to add is I've seen some questions about whether children can get MIS-C twice. So the answer is yes, but it seems to be very infrequent. I think, you know, we've got 6,000 some children reported to us so far, and I think we're only aware of like 2 or 3 really that seem to have had true MIS-C illness twice after 2 separate infections. Thanks. I think that's all. I think that addresses your question and more for now.
No, thank you very much. That's very helpful information. And we have time for just one more question. So speaking about what you refer to as the number of cases you've seen and the time that you've seen them over, can you please sort of address generally what you know about the long-term effects of MIS-C and what we know about that so far?
This is Shana. I can take that one. There are a couple of studies that are currently going on to look at kind of midterm and long-term effects of patients who have been diagnosed with MIS-C. One of those studies is also comparing the effects in patients who were hospitalized with COVID-19. I can't comment on long COVID versus MIS-C effects, or even those in association with the patients who were hospitalized with COVID, because we don't have that cohort in the study, but there will be some data coming out, hopefully in the next couple of months, looking at those differences and how those children recover over time. I can say overall, the reports we're hearing are that children tend to do very well after MIS-C. But we want to look at this a little more, collect this in a little more of a study fashion than our anecdotal reports that we've been getting. So thank you for that question.
And actually, Shana, sorry, this is Angie, Dr. Campbell. I just wanted to mention we're also asking some of these questions in the Overcoming COVID network, and similarly have data that we're almost done working through, looking at longer term, well,